My name is Ann Radford. I'm a family nurse practitioner student at the University of North Georgia, and today I'll be completing a musculoskeletal neurological examination. My patient, Mr. Anderson, is presenting in my office today. He's a 45-year-old male. About a week ago, he sustained a bad fall. He was running in the woods with his friend. When his friend caught up to him, he said he had a decreased level of consciousness and seemed a little bit more confused. As of right now, he's presenting in my office with right knee pain. He's non-weight bearing on that right leg. He has lower back pain with specific pain to his left buttocks, and he has difficulty standing and maintaining his posture. So to begin with, I'm just going to do a simple neurological status examination. Hi, Mr. Anderson. How are you feeling today?
Pretty good.
Can you tell me your name and date of birth?
Carson Anderson, July 1st, 1972.
Do you remember this bad fall you had a week ago? Do you remember leading up to the fall?
Yes.
Do you remember the fall itself?
Yes.
And do you remember afterwards?
I do.
Do you ever remember hitting your head on anything?
No.
Have you ever had a history of passing out or fainting beforehand?
No.
No? Okay. So as of right now, I can tell my patient he's alert and oriented ×3. He's aware about all the events leading up to the event itself and past, and he has no history of fainting. So just as precautionary, since the witness did say he seemed disoriented and might have bumped his head, I'm going to perform just a quick cranial nerve assessment. I'm going to go through 11 of the 12 cranial nerves. The first one, olfactory, is not something I'll test in the office, but we will start with the second cranial nerve, the optic nerve. To do that, I will do a quick ophthalmic exam. I'm going to look into the back of his eye, look at his optic disc and optic nerves. So you just look forward for me. So I'll come in with the patient at a 15-degree angle. I'll look for the red reflex. I'll go into his eye until I can see the optic disc and optic nerves. And I'll do that on both sides. Again, I'll come in until I see the optic disc and optic nerves. And there's no deformity in the back of the eye. The next test I will do is I'm actually going to test multiple cranial nerves 2, 4, and 6. The oculomotor, the trochlear, and the abducens nerve, they all have to do with the eye. They specifically have to do with the pupillary reflex to light, the cardinal views of gaze, and we're going to check that his pupils are equal round reactive to light, and we're going to do the direct and consensual light test. So to begin with, I'll have him look at my finger. If you just follow my finger without turning your head, I'll go to the 6 cardinal views of gaze, making sure his eyes are not twitching, he's not requiring him to sit back and forth, and that everything is moving equally. The next is going to be his pupillary reflex. So I'll turn on the light of my microscope. I'll look at his pupils with the light, make sure that they're converging. And then when I'm doing this again, I'm going to look at the opposite eye and also make sure that pupil is constricting with the light. And there's no abnormalities there. The next, I'm going to back up to the 4th cranial nerve, the trigeminal nerve. This actually has both a motor and a sensory function. The motor function is going to have to do with his jaw, and sensory is going to have to do with his facial sensations that I will use a Q-tip for. So, to do the motor function, I'll place my hands on either side of his jaw. You can just clench your teeth for me, and then move your jaw from left to right. And that's just making sure that that joint, and he has good motor movement in his mouth. The next, I have a Q-tip, and I'll use both the soft side and the dull side to test his sensation on his face. So if you can close your eyes for me, and you can tell me what side I'm touching you with.
Soft.
And then I'll do the other side.
Soft.
And with that, I can tell that he has sensation of both the soft and the dull. You open your eyes. Sensation. The next nerve I'm going to do is the 7th nerve, the facial nerve. And all I'm going to do is ask my patient to smile for me. Can you frown? And puff out your cheeks. And with this, I'm just making sure that there's symmetry with facial movement, so there's no drooping on one side or the other. The 8th cranial nerve is the vestibular coccylar nerve. This one is actually a little bit in a little more accordance to what's happening. This cranial nerve has to do with both the hearing, and equilibrium of the patient. Because the patient did sustain a fall, possibly his equilibrium might have been off, which could have caused the fall. So we'll do a couple different tests with this. Just make sure that, like I said, his equilibrium is adequate and he's not experiencing any vertigo or dizziness. So the first test I'm going to do is the whisper test. So I'll have my patient, if you don't mind including your right ear. And I will say just a two-syllable word, whisper it, and see if you can repeat it to me.
Apple.
I have my patient include his other ear. And again, I'll say a two-syllable word and have my patient repeat it.
Softball.
Good. The next test I will do is the Weber's test. The Weber's test is going to make sure there's no lateralization from one side of the ear to the other with a tuning fork. I'll straighten the tuning fork, place it on my patient's forehead, and which ear do you hear the vibration in? Yeah. And that's just to make sure there's not any lateralization, like I said, from one side to the other. The next test I'm going to do is the Rhine test. The Rhine test is going to make sure that air conduction is greater than bone conduction. So with this, again, I'll straighten the tuning fork. I'll put it behind the patient's ear on the mastoid process. When he can no longer hear the vibration, he'll let me know. Then I'll move the tuning fork to in front of his ear and to make sure he can still hear that. So we can no longer hear it. And can you still hear it?
Yes.
Alright, and I'll do it on the other side.
Now.
Can you still hear it?
Yes.
Okay. And like I said, that just goes to show that air conduction is greater than bone conduction. The next two nerves we're going to test that go together are the glossopharyngeal and the vagus nerve. This is going to test your hard and soft palate and look at your uvula in the back of your mouth. So if you can open up your mouth for me, and can you say ah, ah? With that, I'm just, like I said, making sure that both the hard and the soft palate are constricting. The uvula is midline, and when he says ah, the uvula is constricting up. The 11th nerve, the spinal accessory nerve, this has to do with more of muscular motor function. So I'll have my patient, I'll place my hands on my patient's shoulders. If you can shrug up for me. Good, with good resistance. And then I'll put my hand on either side of my patient's face. If you can turn to the left for me. Good, and to the right. Good. And that's just to assess the muscular strength of those muscles. And then lastly, the hypoglossal nerve, the 12th nerve, is going to have to do with the tongue. So if you can stick out your tongue for me. Good. That's just making sure that the tongue is midline. It protrudes normally. And if it were to deviate to one side or the other, there is the saying that you actually lick your wings. So if he did sustain a brain injury and his tongue deviated to the left side, we may be able to conclude that there may be an injury to the left side of the brain or to the right side and vice versa. So with that, there were no abnormal findings of his neurological status exam. So we'll move on just to a quick cardiovascular exam. Cardiovascular reasons can be another reason for passing out, specifically to a decreased level of blood to the brain. So I will check his carotids and then do a quick assessment on his 5 points of heart auscultation. So the first thing I'll do is just inspect the neck, making sure that I see good pulsations from the carotid. Then I'll palpate the carotid, then one side before the other, making sure not to include both sides at the same time because we don't want to retard passing out. I'll then auscultate both the delt and the diaphragm on my stethoscope. With this, if you don't mind just taking a deep breath in and holding it for a second, that way we can ensure that no breath sounds are getting in the way of auscultation. Deep breath in. Inhale. 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 And then with the belt, breathe in. Good. Out. And in. So you just want to make sure that you're not listening for any turbulent blood flow or decreased blood flow at either one of your carotids. Then I'll just do move on to the chest and thoracic area. Again, just inspect, making sure there's symmetry, no visible pulsations or abnormalities with cardiac function. I'll palpate the chest. Again, looking for any pulsations or crepitus of the chest. Then I will also take the 5 points of the heart, the aortic, the pulmonic, the Erb's point, the tricuspid, and then the mitral point. And listening for any abnormal S1, S2 gallops or murmurs. And if you don't mind leaning forward for me, I'm going to do a quick little respiratory examination. When you feel my stethoscope hit your back, if you don't mind just taking a deep breath in and out for me. Good. And lean on back for me. We'll do the same on the breath. Deep breath in and out. You want to just go in the lateral position, testing left side to right side, making sure that you don't hear any adventitious breath sounds. And then my hand was on his shoulder just to make sure his chest rose and fall evenly with every breath he took. So from that, I'm now going to move on to the musculoskeletal part of my examination. So we can kind of direct our attention to his more focused parts that are bothering him, that include his knee and his back. So with his back, I'm also going to look at his neck and just make sure that, in his head, to make sure there wasn't any sustained injury. So I'll just take a look at his skull in general, make sure that I don't see any contusions, any dents, anything open or bleeding, any abnormalities that might indicate that he did hit his head on the fall, in which I don't see any. Then I will, if you don't mind standing up for me, I'll have the patient turn. There you go. And I'll take a look at the back of his head and his neck. With this, I'm just making sure that the spinal column is midline. There's no deviation from his head to the left or the right. And then I can actually go around forward and making sure that there's no tracheal deviation from the left or the right, and that his head is positioned equally between his two shoulders. I'll then palpate the neck. Again, just looking for symmetry. I'll go from behind and palpate the trachea. Good. And while we're up at the neck, we can do a small range of motion exam. So if you don't mind looking up at the ceiling for me and look down at your toes, you can look straight and turn your head to the right and turn your head to the left, and then take your right ear to your right shoulder and your left ear to your left shoulder, and then you can just do one big head circle for me. Good. And that is going to test both flexion, extension, cervical rotation, and lateral bending of his neck. Did you experience any pain when you did that? Okay, good. Moving on down, we're going to look at the back and the spinal column. I want to make sure that the spinal column has a normal S curvature to it. The cervical portion of the vertebrae should have more of a concave presentation to it. The thoracic should have more of a convex, and then go down to the lumbar. Lumbar should go back into concave or more lordosis appear to it. Then I will palpate. I'll start at the C7 palpation. It's the most protrudent vertebrae at the top, and I'll palpate down, just palpating for any pain or tenderness, and if he's experienced any discomfort when I'm palpating. And I may palpate some tenderness in the back since he's complaining of some lower back pain. I'm also, at that point, going to assess for any step off, which may be any of the vertebrae if they're protruding out or sunken in, which means it may have a possible spinal injury. Then from that, we'll do a range of motion of the back and the spine. So if you don't mind, just turn it over or bend it down, touch your toes for me. While he's bent down, I'm gonna again look at the curvature of the spine, make sure it's not deviating from one side or the other, make sure there's no scoliosis or abnormalities of that. While I'm here, I'm gonna palpate his hips, making sure that they're equal from left to right, making sure that there's no a limb abnormality, making sure that they are equal, and with the fall he didn't dislocate or sustain a hip injury. So you can stand up for me. Then if you don't mind just bending your back backwards towards me a little bit. Good. If you could do a trunk twist and turn to your right and to your left. And then if you can take your right hand and touch the right knee and do your left to your left knee. Good. And so that's going to, again, assess all his range of motions of his spine and back column. So if you don't mind, you can go on, sit on down for me. So since he was also complaining of some left buttocks pain, I want to go ahead and to assess his sciatic nerve and his sciatic notch. So if you can lay on your right side on. Alright, so to check my sciatic nerve and sciatic notch, I'm going to first find the greater trochanter of his hip, and then I'll find his isthmal tubercle of his butt, which is essentially your two butt plugs that you feel when you sit down. And in between that is going to be your sciatic notch. And you just want to palpate that. Do you have any pain or shooting pain down your leg when I palpate that?
No.
Good. And you do just want to be careful when you do palpate it in case there is a sciatic nerve injury that you don't exacerbate anything. From here, you can go and lay on to your back for me. So if you're complaining of both right knee pain and right leg pain, the next test we're going to do is what they call a straight leg raise test. So all that's going to do is I'll brace my patient behind the knee and on the heel, and I'll lift his foot up. And just make sure he's not experiencing any abnormal pain. With this, they're extending the leg a little bit more than normal, so there may be some discomfort, but there shouldn't be any pain. If there would be to pain anything less than a 45-degree angle, then that would conclude a positive straight leg test, and there needs to be additional diagnostic tests to be done with that. So from here, we're going to go on, since we're on the leg, just go on down to the knee. So you can sit up for me. So the first thing we're going to do, like always, we're going to just inspect. I'm going to look at both of his knees, his left and his right. With the right knee, I can definitely tell there's a little bit of swelling, a little bit more bruising than normal, and that would just be because of the sustained fall. So then we'll go on from inspection to palpation. To palpate the kneecap, there are a couple different landmarks you can use to indicate the patella. Okay. So at the top of it, where his femur comes, it's going to be the top portion of his patella, and then the femoral condyles. And then on the lower lateral portion, you're going to have both your tibia and your fibula condyles. And that's going to essentially make just a big square around your patella. In between that is obviously going to be your patella itself. And so you just want to palpate around, make sure that there's any tenderness, pain. You can both look for a fusion, you can also feel for a fusion. We'll do an effusion test later on. And then below that, you can also feel a little notch below the patella, and on either side, you'll feel a meniscus notch. And if there is a sustained ACL or PCL injury, that would be something that would also be tender on palpation. And if you don't mind standing up for me again, on the back of the knee, there'll be the little indentation or the fossa. You can palpate that, making sure that there's not any bulge or fluid collection or any pain or tenderness. You can sit on back down for me. And then lastly, we'll do a range of motion test on the knee. So the knee can both do a couple different range of motion. So if you can just extend your knee out for me. Good. And you can flex it back for me. Good. And then it can actually go, it can abduct and adduct. So we will just bring it in a little bit and adduct, and then bring it out and abduct a little bit, just making sure that there's good active range of motion. And if you couldn't do it, we can always do passive range of motion if he's experiencing a little bit too much pain with it. The next test, there's a couple other special tests we're going to do since he is complaining of some right knee pain, just to make sure there is no meniscus or ACL or PCL damage that he experienced from the fall. So the first test we'll do is the varus and valgus, which is going to test both the lateral and medial meniscus. So if you can lay back down for me, put your head that way. So we're going to look at the right knee, and what we're going to do is I'll put my left hand on the inner portion of his leg, and then I'll put my right hand on the outer portion, and essentially what I'm going to do is I'm going to push opposite ways and see if there's any discomfort with that. Any pain or discomfort?
No.
And then essentially I'll just switch my hands and do it the other way. And like I said, that's going to test both your lateral and your medial meniscus. The next test we'll do that is specific more to the ACL and PCL. So if you can flex your knee up for me. Good. I'm actually going to kind of sit on his foot just a little bit, just make sure it holds into place. We're going to do the anterior and posterior draw test. This is going to, essentially what you're going to do is you're going to put the pads of your fingertips behind the knee. You'll take your thumb and you'll put them on both the tibia and fibula condyles, and you're going to kind of want to push back, and you're going to want to pull forward on them. And that's going to make sure and see if that meniscus, make sure it has a little bit of lax, a little bit of play in it, but not too much to the fact that it may be out of place or there may be some fluid behind there. And we will also, since we have the knee flex up a little bit, you can also do another test, the Lachman's test. Lachman's test is very similar. It's a little more specific to the ACL, but it's going to be, as far as like the same conclusion, it's going to be essentially the same as with the anterior and posterior drawer. So for that, I'm not going to do it because it's a little bit of repetition. And so then one of the last things we'll do for the meniscus is the medial meniscus injury. So I'll have my patient just kind of straighten his leg out just a little bit. Similar to when we test the varus and the valgus, I'm going to put my hands in a similar position. So I will put my left hand on the interior portion of his knee, and then I'll put my hand underneath his heel. I'll flex my patient's leg up a little bit, and then I'll extend it and then externally rotate it. And with this, I'm looking for fluid motion with the knee, making sure there's no crackles, pops, or crepitus experienced in between any of the ligaments or the patella itself. And so the other test we can do, like I said earlier, for a fusion, you can always look for a fusion, just any swellingness or swelling of the knee, and you can see a little bit of it. So there's two tests you can do, the Blotman's test and then the balloon test. It's kind of similar to both the Lachman's and then the varus and valgus. They test the same thing, but you can do either one. So the balloon test is the one I'll do. So essentially you can take your non-dominant hand, you'll start on the up on the thigh. You'll kind of scrunch down both the skin and fluid onto the patella, and you'll just see if any of the fluid is displacing. Then you can go laterally and medial and see if there's any displacement from one side or the other. You can also do a quick tap of either side of the knee and see if it's more of a ripple effect, if like I said, if there's any effusion or built up fluid behind that knee or patella. And so then the last thing we'll do, one of his last complaints is he was also complaining of some sharp pain to his calf area. So what we'll do, since he did sustain an injury to his leg and he is non-weight bearing, he might have been a little bit more of a sedentary lifestyle at home, laying down. So we just want to double check and make sure there's not any DVT to that calf or a risk for one. So we'll just do a quick, what they call a Homan's test. So it's very simple. So I'll have my patient just flex this foot back for me. Good. I'll raise it off the bed, and then I'll just palpate the back of the calf and see if there's any tenderness with that. And if there was any tenderness, we can also do further diagnostic testing to conclude if there is or is not a DVT. And so, like I said, this was a focused examination. So if there wasn't any area concern, you were to do every musculoskeletal examination bilaterally on the left and the right. But since his right knee was the only one that was bothering him, that was the only one that was focused on today. So relatively, the exam was inconclusive or a normal finding as far as neurological status. But the musculoskeletal status is just something that it may just take some rest and some time to get over. So thank you. I hope you enjoyed.